Dear friends, my left, Dr. Simi Monucha. She is consultant cardiologist working in Ascot Hospital, and she is a academic counselor in our community cardiology program. Next to her, I am very proud to introduce Dr. Ravi R. Kasliwal. He is director in non-invasive cardiology, Ascot Hospital, and he is also program director of DNV cardiology program. He has several publications regarding the cardiology, and he also received many awards, including prestigious B.C. Roy National Award. And he is our program in charge in Ascot Hospital of our program. And next to Dr. Ravi Kasliwal, he is Dr. Manish Bansal, and he is a consultant cardiologist working in Ascot Hospital, and he is also our academic counselors. Now I would like to hand over this topic to Dr. Ravi Kasliwal to continue the session. Dr. Ravi Kasliwal, please.
Thank you very much. Hello, colleagues. Talking to you about echocardiography from New Delhi. Now, if you look at the history of cardiology, more progress has been made in the last 30 years than the last 500 years. But truly, Leonardo da Vinci, and you heard his name, there's a movie going on based on this man's work. Leonardo da Vinci first described the heart and the arterial system, and this was way back in the Renaissance period in Europe, 1452 to 1519. And then William Harvey, following that, an English physician, actually described the arteries and the veins, and he just didn't know about capillaries, but otherwise he gave a very graphic description of the arterial system. And then René Laennec, who was a Frenchman, described he had problems because, young female patients, they used to cough. He wouldn't know how to really get to those sounds, and therefore he discovered the beginnings of the stethoscope. And the stethoscope has become such an important tool. I think as medical people, we are known because we carry stethoscopes with us, and it gives us huge information clinically. But really, the start of echocardiography can be hinged to this man, Ingi Adler. Ingi Adler was a Swiss gentleman, and he, along with Hertz, were the two people who first described a process by which, and they used to call it sonar at that time, because it's a very interesting story. Dr. Adler was actually walking on the beach just after the Second World War with his son, and his foot, with the son, was walking. He came across a metallic thing, and he said, "Dad, what is this?" And he said, "This is the sonar by which, from when we are in the submarines, we can actually look at enemy ship or a whale, or so and we use the principle of sonar, and the principles of echocardiography are actually based on sonar." Just look at their machine that they first devised, and what a huge machine this was. And I tell you, this was the most difficult way of getting an ultrasound. Ultrasound in the early days, you had to sit in a tub, and there was a large machine. It was almost used to look like a mainframe of an echo, a mainframe of a computer. Now you know how small these machines are. They can actually be taken in as a laptop. So this is what the early days were. So echocardiography is now of science almost 52 years old. And it has changed the very face of cardiology. Dr. Bansal, who will go through some of the general principles of how you use this machine to get optimized pictures, and then we go on to the more relevant clinical work which we are all dying to see.
Thank you very much, sir. Since the time Adler and Hertz first developed an echo machine, several technical advancements have taken place in the field of echocardiography, and today's echocardiography machine is really a sophisticated device. It's really a high-end device, but all the echo machines can be broadly categorized into three main components. These are transducers or probe that we apply to the patient's chest wall for acquiring images. This is the monitor, which is used for displaying the information, and this is the processing unit, function of which is to process the data that we receive through the probes and display it in a meaningful fashion on the screen. So transducers or the probes, as I mentioned, are the devices that are used for gathering the information These are the devices that generate and receive ultrasound waves. So the main component of a transducer is a piezoelectric crystal. This crystal has a unique property that when electric force is applied to this crystal, it undergoes deformation. When the electric force is removed, it assumes its shape again. This process of deformation and assumption of shape again results in generation of ultrasound waves. This happens in reverse direction also, that when ultrasound waves hit this crystal, it undergoes deformation, resulting in generation of electrical force that can be processed to form image. There are several types of transducers that are available for use. These can be classified according to two main aspects of the transducers. One is the frequency of the transducer, and secondly, the technology that is used for manipulation of the ultrasound beam. Transducer frequency is probably the most important component, the most important feature which decides what probe we are going to use. Higher the frequency, better is the resolution of the image, but penetration is poorer. So we have to strike a balance between resolution that we want in the image and the depth at which we want to examine the tissues. Given a choice, we will always prefer to use a probe that has highest frequency, because that will give us the best resolution. But that is not possible. So in neonates, when the chest wall is thinner, we can use a probe that has higher frequency, usually between 7 to 7.5 megahertz. In children, we cannot afford to use this high frequency, so we use a probe that has a frequency between 3.5 to 5 megahertz. And in case of adults, we can use probes, usually only those probes that have frequencies between 2 to 2.5 megahertz. Now, another aspect that determines what transducer we are going to use is the technique that we are going to technique that is used for manipulation of the ultrasound beam. Earlier machines had provision of imaging in only one direction, only one line. With that, we were not able to develop a cross-sectional image of the heart. So it was necessary that we developed a mechanism to move the beam from one end to other, so that entire image of the heart could be generated. So the earlier most devices were fitted with mechanical motors. These motors used to oscillate or rotate the elements. That's how the ultrasound beam was moved from one end of the sector to the other end, resulting in formation of the image. But these probes were very bulky, and they had the problem that they were prone to malfunction of the motor, resulting in these probes becoming non-functional. So these probes were given up, and all the probes that we use now use electronic mechanism for manipulation of the beam. There are two types of mechanism that are used for manipulation of beam, the probes that we use nowadays. One is linear array and second is phased array. This is an example of a linear array probe. In linear array, there are multiple crystals which are arranged in a series, and each crystal fires sequentially. So when one crystal fires, it results in formation of a beam. After some time, second crystal fires, that forms another beam. So that is how the ultrasound beam is moved from one end of the image to the other end, and we get a parallel broad beam. Advantage of this probe is that it gives a broad sector. It is useful in imaging the vessels, also in abdominal examinations. But the problem is that this probe is very broad, and we need to have a wide acoustic window to be able to use this probe. And another problem with this probe is that it can the beam that is generated with this probe cannot be focused. So there is another technique used for manipulation of ultrasound beam, that is called phased array technique. This is actually not a phased array probe. It's somewhere between linear and phased array, but I'll explain the principle on the basis of this diagram. In this also, there are multiple crystals which are arranged in a series, and these crystals fire sequentially. But the interval between firing of the two consecutive crystals is much shorter as compared to the linear probe. As a result, all the crystals generate one single beam. Unlike linear array, where each crystal results in formation of one beam, in phased array, all the crystals together form one beam, and direction of this beam and focusing can be brought about by altering the sequence in which these crystals are firing. So this was about transducers. Now I'll briefly describe some of the controls that are used for optimizing the image that we get on the monitor. Gain is the control which we use very frequently. What gain does is that it uniformly reduces or increases the amplitude of all the echoes that we are receiving. For example, in these are the echoes that are being received, and on this axis is the amplitude or intensity of the echo. So if we reduce gain, all the echo signals get affected equally. Intensity of all is reduced. So that is how gain function works. But very often the problem with gain is that we cannot selectively change the intensity of echoes coming from one particular point in the entire image. For that we have few other controls. This is time gain compensation, also called as depth compensation. It's another very frequently used control on the echo machine. In this there are multiple levers arranged in a sequence, and each lever depicts a particular depth of the image. So by altering the position of these levers, we can alter selectively the signals coming from a particular depth within the image. There's an example here. These are the echoes coming from the tissue. This is the position of different levers. Here we have increased on this side we have increased the gain compensation, and here we have decreased. So as a result, these echoes are reduced in intensity and these echoes are enhanced. So that is how we selectively modify the image that is being displayed on the monitor. Now, unlike time gain compensation and gain, in reject we do not change the signals, but we set a threshold beyond which the signals are being displayed. This is normal without any reject. All the echoes are being displayed. If we set a reject level or threshold at this point 1, this dotted line, this will eliminate this echo, and this echo signal will not be displayed, as in the case in B. If we raise the reject level or the threshold, this echo will also be eliminated, so only these will be displayed. Another control which is again used very frequently is compress, actually known as dynamic range compression. Short form is compress. In this we don't change the signals that we are receiving. This functions in a different fashion. Actually, when we do echocardiographic examination, we receive thousands of signals, but the monitor that we have do not have capacity to display all the signals. So what we do is that we logarithmically reduce the range of signals, and from this 0 to 100 decibels, logarithmically this is reduced to 0 to 30 decibels. So now this range can be displayed and all the echoes can be displayed on the monitor. If we do not use compress, we will not be able to display all the signals, and some of these signals will be eliminated completely.
Some of these things look fairly intimidating. Time gain compensation, compress, a linear array, a phased array. But actually when you start doing actually an echo, and we shall show it to you how this comes about, this becomes very natural. What Dr. Manish Bansal is trying to tell you is how to get an optimized image at a point of time when you start doing it yourself. And for that, these 3 or 4 things are important. If you look at the first book on echocardiography, these are also detailed very well there. So don't worry if some of this sounds or looks intimidating right now. You will be able to gauge it as we go along.
The earliest mode of echo that was developed was the A mode. What was done in this was that every echo was displayed in the form of a spike, and length or height of the spike was proportional to the intensity of the echo signal received. In this example, these are the 3 structures that are reflecting the ultrasound beam. This is the position of the probe or transducer. Ultrasound beam is coming in this direction and is getting reflected. This structure reflects maximum ultrasound waves. This is reflecting relatively less number of waves, and this is in between these two. So in A mode, this signal will be displayed in the form of a spike. This is displayed here, and ultrasound beams which are being reflected from this are displayed here. The amplitude or height of these 3 spikes is proportional to the intensity of the ultrasound signal that is being received. Now in this, imaging could be done only along one line. We didn't have any second dimension, and if there was movement in any source from where the beams were being reflected, if that source was moving in the same direction, it could be depicted as movement of the spike in the same direction. Subsequently, B mode was developed. In this spike was replaced by a dot, and the brightness of the dot was directly proportional to the intensity of the echo signal received. So it is also called brightness mode. Now again, there was only one dimension, and imaging was done only along one line. After that, the next mode was that was developed was M mode. In this, what was done was that echo signals were depicted or plotted against time. So since this object is stationary, so this dot will remain in this position throughout the scanning. So we will get a flat line here, a straight line. Similar is for this, but since this is moving, so when we plot its movement against time, we will get this kind of curve. So that is how M mode imaging was done. But all these are along one line. We cannot get full sector of image using either A mode, B mode or M mode. Subsequently, 2D imaging was developed. In this, in M mode, A mode or B mode, only imaging only along one line could be done. Now this is line along which ultrasound beams are moving. So in 2D, mechanisms were developed to move this beam from one end of the sector to other end, as we mentioned in linear array or phased array probes. And by moving this ultrasound beam sequentially, we could get slices of the tissue, and when these slices were summated, this could be reconstructed to generate a cross-sectional image of the heart or any other structure. So now we'll show you a video clip describing all these and features of the components of the echo machine and various controls used. Echocardiography machines have broadly three components. One is transducer or probes. Second is the processing unit, this entire thing, and finally monitor. The transducer or probe, as the name suggests, is used for transmitting and receiving the ultrasound signals. This is the component which is applied to the patient's body also. This is the processing unit, main function of which is to process the information which is obtained using this probe and then displaying it onto the monitor. So we'll first discuss a little bit about the transducer. As I mentioned, that transducer is the component which is used for transmitting and receiving ultrasound signals. So the main component that is used for this function, or that transmits the ultrasound waves and then receives it back also, is a crystal called piezoelectric crystal, which is present in all the transducers. The special property of this crystal is that when electrical force is applied to the crystal, it undergoes deformation, and when the force is removed, it assumes its shape again. So that deformation and reformation process results in generation of sound waves, ultrasound waves, which is used for transmitting the beam into the patient body. And similarly, when it receives ultrasound beam, it undergoes deformation, which results in generation of electrical impulse that can be used as a signal. So that is how a probe functions. Now there are different types of probes used for different purposes. The probes differ mainly in two aspects. One is the frequency that it emits, and second, the technology used for moving the ultrasound beam. Now these are various probes. These are two different probes. The number written here denotes the frequency that it emits. For example, in this case it is S3, so it emits ultrasound waves that have frequency around 3 megahertz. Similarly, this probe has S12 written on it. That means that it will emit ultrasound beams that have frequency around 12 megahertz. Ultrasound beam that has higher frequency has better resolution, but its penetration into body tissues is poorer. For example, this probe, this will have good resolution, but it will not penetrate deep into the tissues. So it can be used for imaging in cases of neonates. But if we want to image adults, we'll have a probe that has lower frequency, because that will provide better penetration. However, the resolution will be poorer. So in case of adults, we use a probe that has a frequency around 1 to 3 megahertz. In case of children, we use a probe that has a frequency between 3.5 to 5 megahertz. And in case of neonates, a frequency ranging around 5 to 7 megahertz is used for imaging. Now the other aspect in which these probes differ is the technique that is used for moving the ultrasound beam from one angle to other. Like in this, if we want to image a cross section of the heart, we'll have to move ultrasound beam from one end to other end. The earlier probes had motors, mechanical motors fitted within the probes that used to rotate the crystal, the piezoelectric crystal, to move the beam. Now these were the probes that were very bulky and outdated nowadays, not used. The technology that we use nowadays for moving the ultrasound beam is predominantly electronic. There are two different ways in which we can move the ultrasound beam. One is linear array and second is phased array. This is a linear array probe. In this, there are multiple crystals arranged in a series that fire sequentially to generate a linear beam. This is a parallel beam. The major problem with this probe is that this requires a wide acoustic window, and secondly it cannot be focused. As compared to this, these probes use a technology called phased array technique. This also has multiple elements, multiple crystals, but ultrasound beam in this is moved by timed firing of different elements. The timing is set as per the requirement. So in this, these probes have smaller size, can be used for imaging from narrow spaces also, and secondly the beam that is generated by these transducers can be easily focused. These linear probes are used mainly for imaging vessels like an arterial or venous Doppler, because the vessels are close to the skin surface, and in that situation these probes provide good resolution, and a parallel beam provides good imaging window. All the probes have a marker on one side, like in this it is here, in this probe it is here. This marker helps in localizing the image on the screen or the monitor. This small circle, it denotes the side on which the marker is present on the transducer. So if we are holding the transducer like this, marker is on this side, so structures that are present on this side of the probe are displayed on this side, and structures which are present on this side of the probe are displayed on this side. So that is how we localize the image on the monitor using this marker and this dot here. This is the component of the echocardiography machine that provides user interface. Different machines have different configuration of this segment. This is a Philips equipment. In this there are four main components or segments. These are two touch screens. This screen has controls that are used for setting up an examination. That is that we can choose the preset we are going to use, we can choose the probe, we can select store images from controls present in this screen, and in addition this screen also has controls for analysis. This touch screen has controls which are specific for a particular examination, like whether we are going to use 2D or color Doppler or M mode. Likewise, this segment has a keyboard which is used for keying in the text data, for example patient's name and other information, and here are the controls which are used for adjusting the image and for deriving different type of information. This is the knob used for adjusting gain, this is for compress, this is for the adjusting the size of the sector, position of the sector. These are for measurements like caliper, trace. This is for adjusting time gain compensation or TGC. This is for lateral gain compensation or LGC. This touch screen has controls that are required for setting up an examination. That is, we can choose a preset from this. Preset means that we have predefined settings used for a particular type of examination. For example, if we want to do echocardiographic examination of an adult, then we'll choose cardiac exam adult. In case of a child, we'll we may prefer to use pediatric. Similarly, for vascular examination, we have different presets. Also, we can choose from this screen is the probe that we are going to use. Then there are settings for storing the images and also various controls for analysis. This screen has controls that are specific for a particular examination. That is, whether we want to use B mode, M mode, color, or pulse Doppler, and for settings pertaining to each component. Like for color, we can set gain, focus, scale, etc. Similarly, for Doppler, for M mode, different settings are present which are used for a particular examination.
Thank you very much, Dr. Manish, regarding the. Thank you very much, Dr. Manish, regarding the brief presentation of this echo machine, transducer, and other aspect of this echocardiography.